Hi, good afternoon, everyone. This is Amelia Keaton from the Tennessee Department of Health. Today's going to be a little different. We'll have a few different speakers. One will be Vicki Reed, who's one of our infection preventionists based in Nashville. The second will be Fabiola DeMuth, who I believe everybody has heard a few weeks ago, who is also one of our infection preventionists based in Nashville. Let me go ahead and share my slides with folks. All right, so we've got a pretty packed agenda for today. So we'll go through our regular Tennessee Department of Health COVID-19 updates. We'll briefly go over some CDC guidance. Vicki Reed is going to go over our NHSN updates, as well as some help in navigating the Tennessee COVID-19 website, which I know can be a bit of a bear just because of the sheer amount of information that's on that site. And we'll also have some helpful tips from our infection preventionists related to face masks and N95, and then we'll also revisit environmental services, or EVS, because I know that's something that has created a lot of questions, and we want to try to help make sure that we provide as much information there as possible. And if folks listened to our call a few weeks ago about environmental services, this will reiterate some of that information and hopefully provide some other helpful tips. I tried to compile some of the most frequently requested guidance that we've heard folks needing. So we have our general public health guidance, which includes documents from my program, which is the Healthcare Associated Infections Program. This also has the information on weekly testing, laboratory options for weekly testing, and a few other helpful resources there, including how to request PPE. If you have any specific questions about testing your employees or others in your facility in general, we ask that you email covid19.testing@tn.gov. For questions about payment, billing, and reimbursement, please email covid.invoices@tn.gov. And questions specifically about regulations and the emergency rule from our Office of Healthcare Facilities, please email ohcf.health@tn.gov. And I also provided a link here to their website as well, which has some of those documents available for you to download as well. So you have been asking, and we have been trying to work within our website developers to get our weekly recordings posted. So we had our first recording of this call posted last week. Here's the website on how to navigate it. It's available on YouTube. Which essentially will look exactly the same as the file link that has been previously sent out by WebEx. I'm trying to work on getting those sent, prior calls added to our website as well, so more to come on that, but hopefully this will be a little bit easier for everyone to access if they're not able to join the call or if they want to access the materials after the fact. A question that we've been getting a lot of inquiries about, and that I know can be a little bit confusing, are testing results that are considered, or that some people think may be false positive. And so that means that an employee or a resident of your facility tests positive and you think that it might not be an accurate result. These are really difficult to prove as being a false positive result for a couple of reasons. So one is that asymptomatic transmission is really common with COVID-19. I think we've seen, both in outbreak situations in long-term care facilities and in the general public and in other healthcare facilities, that people may have absolutely no symptoms, or they may be, prior to developing their symptoms. And so, in that setting, it can be a little bit confusing when they test positive for COVID-19. But with that said, we know that those asymptomatic people are still a really important mechanism of transmission to other people, whether it be patients they're taking care of, caregivers of those people, or people that are just in their household or that they have had close contact with in some other setting. Another complicating factor is that likely because of the sheer volume of asymptomatic transmission that we're seeing, at least half of infected people in Tennessee, when they are interviewed, do not know where they could have been exposed. So they can't pinpoint a specific individual or contact they had that likely resulted in them getting COVID-19. And, because of the importance to transmission in the community of asymptomatic individuals, you can't really disregard a positive COVID-19 test result in a person who's asymptomatic. This is especially important in nursing homes and long-term care facilities because incorrectly interpreting that test result can lead to inadvertent disease transmission to a wide variety of other people in the facility. And so we take these results very seriously because they have infection prevention and control implications throughout the facility. Another complicating factor here is that interpretation of results from specimens collected at different time points is hard to do. The reason for this is that viral shedding can vary dramatically within the same person during the course of infection, even on the same day. The amount of virus that's detected on one of these tests also depends on how the specimen was collected, how it was stored, how it was shipped. We also know that different labs have different assays that have different levels of viral detection. And so when you get a positive or a negative result, that's based on, what the assay detected. And so for those reasons, we are really encouraging anybody who thinks that they have a result that's not accurate to call and contact the lab that performed the test and have them determine if there were any quality control issues or any contamination events that may have resulted in receiving a positive result if you think that that's not truly accurate. In the absence of one of those, rare events where the lab had an issue, our office, will treat these results as positive, unfortunately. And I know that that can be confusing. And, this is one of the few diseases where we have really encountered such, widespread transmission. But I think just because of the fact that we know asymptomatic people infected with COVID-19 can still spread it, we have to take those results as accurate when we receive them. So hopefully this provides a little bit of the context for why we are so stringent on accepting these results, but feel free to let us know if there's any other questions. In terms of where we are in Tennessee, I imagine it's no surprise to anybody on the phone today that we have been seeing an increase in cases across the state. Even in areas where there wasn't a lot of transmission previously, we're seeing new record highs of transmission. So as of yesterday, there were 1,350 new cases identified within the past 24 hours. Those are sort of happening across all age groups, but also also increasingly happening in younger patients, which is something that I think previously people had thought that those folks were less likely to be infected, which is not the case as we're seeing. In terms of epidemiologic updates in long-term care facilities, we have now identified 192 licensed facilities with one or more cases of COVID-19 among residents or staff. That's an additional 27 facilities from this time last week, so a huge increase there. We now know that the breakdown is 134 skilled nursing facilities. That's an increase of 17 from last week. 55 of those are assisted living facilities. That's an increase of 9 since last week. And 3 residential homes for the aged, and that's an addition of 2 from this time last week. And I will also add that these numbers were taken from a cluster report that was collected on July 3rd. And so, I can say that we have received reports of other clusters and outbreaks within facilities since that time. So I imagine this number will be much higher next week too, unfortunately. In terms of the cases in this breakdown, over 1,200 residents or patients have been diagnosed with COVID-19 since we started tracking this several months ago, and over 650 staff members have been diagnosed with COVID-19. In terms of updates from the CDC, something that was brought to our attention and that I don't think has been widely publicized is that in areas of the country where there is moderate to substantial community transmission of COVID-19, which I think Tennessee unfortunately qualifies as at this point, the CDC is now recommending universal eye protection in addition to universal masks for any patient encounter. And that includes anybody who may not necessarily be under suspicion for COVID-19, again, likely because of the high rate of asymptomatic transmission. So I've tried to highlight the link here that kind of goes through this guidance. It's buried on the CDC website, and I apologize for not including the link here, but I can certainly include that afterwards. But the kind of important part is that everybody should continue to wear a mask, both in the community and especially within your facility if you're a healthcare worker. Workers should also wear eye protection in addition to their face mask to ensure that the eyes, nose, and mouth are protected from splashes or sprays. I actually reached out to the CDC directly to get just more input on why this guidance was changed. And they had a couple of reasons. So, obviously we know that asymptomatic transmission is increasingly leading to outbreaks, and we know that transmission occurs via small respiratory droplets, and those can come from talking loudly, from coughing, from sneezing. Eye protection provides additional mucous membrane coverage since some of those droplets can enter the respiratory tract via the eyes. We also know that splashes and sprays are not always anticipated. So even in patients who are asymptomatic, they may be incubating COVID-19. And so this provides an added level of protection there. And just kind of an added benefit of using eye protection is that we all touch our faces so regularly, and while the mask probably discourages us from touching our mouth or our noses frequently, the idea is that by having some kind of eye protection, whether it be goggles or a face shield, that you are less likely to rub your eyes or touch your eyes when you're at work. And then finally, something that may not have been widely known and that is probably worth taking a look at is CDC's guidance on risk assessment and when to exclude folks from work who are healthcare providers. This guidance says that for somebody who comes in contact with a confirmed COVID-19 case and is not wearing eye protection, but all other elements of PPE, that those workers should ideally be excluded from work. We know that that's not necessarily possible in the majority of cases, particularly in situations like we're currently in where staffing is so limited. But I think this is probably more in line with that guidance. And so if you're wearing universal eye protection at all times, this decreases the likelihood that you will need to be excluded from work for that purpose. And so with that, I'm going to try to pass things over to one of my colleagues, Vicki.
I just wanted to go over the Tennessee website and show you a couple of things here. So when you first go on, you're going to pull up the tn.gov/health. And when you get there, you're going to click on the yellow banner, and it will take you to the COVID-19 website. Next slide, please. Okay, so as you scroll down in this map here, you can click on this for your data for county level information. So once you click on that, it will bring you up to the epi curves. Next slide. And this is where you will find it can be by county or by region, and this will be the new cases reported daily. Next slide. And so you'll just keep scrolling down. And then here is where you will find your information for whether your county is under or above the threshold for you to allow visitation in your facility. As you can see here, Davidson County, of course, I'm not sure we ever have met that, is above the threshold. Next slide.
Oh, and I will also just add briefly here that the threshold that we're using is the average number of new cases per 100,000 residents over the past 14 days. So if your county has had an average of less than or equal to 10 new cases, you're below that threshold. If it's above those 10 cases per 100,000 residents, you're above it. And so visitation should be discouraged. So sorry, Vicki, I will right back to you.
That was great information. So here is just the CDC updated guidance that we've talked about that was updated on 6/25. And so you can kind of see the new things, a summary of changes to the guidance. So when you're looking in this, just be sure that it's dated at least 6/25 or newer. Next slide. So also I wanted to cover in the website of congregate settings. So this is where long-term care facilities are going to go to find information that we have posted to the site. And you will just, once you go onto the website and you've clicked on the yellow banner, you just keep scrolling down. This is kind of under that map and it says congregate care settings. Next slide.
And just to add, we're also including that under healthcare providers and laboratories as well. I just asked this morning to make sure that the information is present in both places, just because I know people may interpret it differently. So just an quick update there.
Okay, great. Yeah, we need it in lots of places. So here's what you're going to see there when you go to the congregate care settings. In the healthcare providers, it's going to be, you can find out about the weekly staff testing. You can find out about the long-term care facility visitation. Also, you'll see the date that when they were last updated. So for the nursing home staff testing, it was 6/23. And then for the facility visitation guidance, it was 6/15. The last time I looked was Monday. So I don't think anything's been updated since then, but this was the last dates that I've seen. Okay, next slide.
Okay,
Okay, so this is some little mini webinar series that CDC put out. We know that long-term care staff doesn't have a lot of time to sit down and view webinars. So these are nice little mini webinars that, as you can see, the longest one is 12 minutes and it's on PPE. So it kind of gives them a little chance to just to kind of sit down and review some of these modules. Next slide. All right, so this slide here, you can kind of review. This is just some additional resources that we kind of keep on there for your convenience. Next slide. So as we know, with the uptick in the new cases, there may be a time that you're going to need to know your regional healthcare coalition contacts. So I just wanted to leave this on there so you can have a quick reference to that. And then on the next slide is the link to for the PPE from TEMA. Next slide. Okay. Okay. So
sorry, it's a team effort.
That's fine. So I want to go over some NHSN data. And so this map here this is just aggregate data by the region. Now this is through July the 6th, and this is the cases for residents of confirmed and suspected cases in long-term care. So this is since we started recording data. And then on the next slide,
and this is just the confirmed and suspected cases in staff and long-term care facilities. So similar graphic, just broken down by staff only.
All right, thank you. Okay, so now I'm going to talk about the NHSN data, and these are counts that was for the week of 6/29 through 7/5. So this is what you have reported to NHSN. So for resident admissions, we had 36. In confirmed cases, we had 59. Suspect cases was 58. In COVID deaths was 19. In our staff, we had 131 confirmed cases. And then for suspect cases, we had 77. Okay, next slide. So on Monday, July the 6th, NHSN users received an email about changes to the module. So the resident impact pathway now has a dashboard, as you can see here, and this will be a summary of your weekly data. And you'll access this by the blue navigation bar on the left in NHSN when you sign in. And then on the next slide, this is part of the dashboard, and this shows your confirmed cases and then your COVID-related cases. So NHSN has already started working on the next edition, and this will continue for the additional pathways and analysis options. So they're trying to work through getting some analysis that you can have for your data. Now, NHSN also has a newsletter that comes out quarterly, and this was sent out Tuesday on the 7th. So please check your email. It has many of the updates in it for the COVID-19 module. All right, next slide, please. So one of the changes that NHSN has recognized that some facilities, of course, are setting up COVID units to receive transfers from your assisted livings or your sister facilities. So the admissions definition has now been revised to include those admissions and readmissions who were previously diagnosed with COVID from another facility. So it won't be just from the hospital anymore. It's now going to incorporate admissions from other facilities. Now you can go back and update your previously entered admission counts, but this is not a requirement. Next slide, please. So they're also trying to improve the quality of the data being reported. So users will notice pop-up alerts as a reminder of potential data entry areas. Like if you try to report more COVID deaths than total deaths, as you see here, there will be a pop-up with the definition of the data that is expected. Next slide, please. Thank you. There's non-modifiable fields have been added to each of the 4 pathways. So if we look at the date created, this is the date and time that you're entering the data, whether it be manual or CSV, and this date cannot be modified by you. This date, of course, must be within 7 days of the last date that you entered the data. If the day is on the 8th day, you will be out of compliance with your CMS reporting requirements. The facility CCN and facility type will populate, and this allows you to quickly verify the information that's associated with your data that's being sent to CMS. Okay, next slide, please. So as you can see here, the date for which the counts are reported, that's on 6/1. And then here's where you'll see your facility CCN and your long-term care facility. And this is where you'll verify that this is correct. And then if you'll notice here, the date created, that is the date that you're actually entering that data. And as you can see here, they were entering data for 6/1 on 6/18. So be careful not to do that. All right. Next slide, please. So I also wanted to review again, kind of how important that is that you report it daily or at least every 7 days. Okay. I think we covered this last week on to meet the suspected criteria that you must show signs and symptoms for that to be in that suspected bucket. And we also had this question last week about if a suspected case later tests positive. We had some questions on that. So we did email NHSN, and this was their response. If the resident would count once when they become suspected and then count positive when the result comes back. So you would have a count in each bucket. So that's kind of why it's important that you collect this data every day around the same time every day, because like on Monday or Tuesday, they started showing symptoms and they are a suspect case. Then on Thursday or Friday, you get it back confirmed case, then you're going to report it as a confirmed. Next slide, please. So another question that was emailed to NHSN was about shared staff. So if a staff member tests positive for COVID-19, each facility that staff member is employed will need to record the event. Even if the employee has not been in that facility, for example, a month, the reporting facility must count the staff member as a new positive. And this would be like for your PRN staff, and maybe they don't work as much, but you still need to report them as one of your positives because they are under your umbrella. Next slide, please. So this is a slide that we've had in So this is where you go to find your published data that has been sent to CMS. The data is now through week ending 6/21, and this is on every Monday. And then, of course, if your facility's data does not appear on the CMS website, you're going to need to contact CMS through that link, email. And then for the CMS enforcement related questions, you'll use the enforcement email. Okay, next slide. So the next few slides, we're going to cover the differences and degrees of protection provided by face covers, face masks, and N95 respirators. Next slide. So PPE is personal protective equipment, and it is worn during the course of care to protect both the healthcare worker and the residents. Now, there's been some confusion about what is the appropriate face coverings or masks or respirators to be worn. So I'm hoping on the next few slides, I can help to clarify the different options and appropriate times to wear each one. Next slide. So we're looking at N95s. We're going to look at face mask and cloth face coverings. We're going to run through them here. All right, next slide.
Sorry about that, Vicki. I butchered the animation on the previous slide.
Okay. So what are cloth face covers? Of course, they're strictly used to provide source control. They're not personal protective equipment, so they should never be worn by a healthcare worker when there's a situation where there's a potential exposure could occur. They're meant to contain secretions at the source, so protect those around the wearer from any possible secretions from the person wearing the mask. In the healthcare setting, if a healthcare worker is closer than 6 feet to a resident, something more protective than a cloth face cover should be worn. It is only appropriate for staff to wear while working if they are not providing direct patient care. Now, if the staff are wearing a cloth face cover, they should also practice physical distancing from co-workers and residents to be protected. Next slide. So a surgical mask or a procedure mask provides protection to the wearer and is considered personal protective equipment. A surgical mask is preferred in situations where the mask might become wet from splashes or sprays. A simple face mask or procedure mask is appropriate for other isolation situations where splashes or sprays will not occur. Now, in situations where the mask might need to be reused, be sure staff have a safe method to store and that the mask is not in any plastic container or bag that would not allow it to breathe and dry out. If reused, ensure that the mask is not visibly soiled or compromised in any way. If it is, do not have the staff reuse it. The soiled or compromised mask should be discarded. Next slide. An N95 is not a mask. If properly fitted through fit testing and a fit check prior to use, they do filter out 95% of the airborne particles. If you've not been properly fit tested, they may only be as effective as a surgical mask and not provide the filtering of the airborne particles. And of course, they must fit snugly against the face so they are not protective for anyone with facial hair, and not everyone can wear the same style respirator as the fit will depend on the shape of the face. Now, a surgical N95 provides fluid protection against sprays and splash, but a standard N95 would not. A valved N95 does not provide any source control, so it's not recommended in the healthcare settings. N95s are recommended to be worn during aerosol generating procedures. There are several KN95s that are considered compatible to the N95. And when fit testing, consider only fit testing the staff who will be using them. Now, if you are having your whole facility to wear N95s, of course, you're going to need to fit test your whole facility. Now, your facility can have its own respiratory protection program, or there is some options for fit testing is to use an occupational healthcare company who contracts with you to provide this service, or possibly through your local emergency partners. Next slide. So in the settings of COVID or suspected COVID, and as Dr. Keaton spoke of earlier, and in areas where there's moderate to substantial community transmission, you'd need to use contact and droplet precautions to be put into place. The required PPE, of course, would be the gown, the gloves, the eye protection in the form of goggles or a face shield, and a face mask, a surgical mask, or an N95 respirator. Remember that a face shield does not replace the mask or an N95, but it must be used in conjunction with a mask or an N95. A face shield is designated to protect the eyes from splashes. One last reminder about the use of cloth face covers. Remember, they're only used for source control, so it could be used by residents, like when the staff would wear a surgical mask or procedure mask when they're doing personal care, or like visitors. If staff use them, they cannot work directly with the residents and must be physically distanced from coworkers. So that is my presentation, and I think that we're probably going to have questions at the end.
Thank you. Good afternoon, everyone. My name is Fabiola. As Dr. Keaton mentioned, I'm one of the infection preventionists based out of the Nashville office with the HAI program. So today we want to discuss environmental contamination with the SARS-CoV-2 virus. We want to look at cleaning procedures. We also want to discuss the hierarchy of disinfectant skill, look at some of the properties of an ideal disinfectant, and also briefly discuss implementation of compliance audits. Next, please. So we know that the SARS-CoV-2 virus can live on surfaces up to 72 hours. And this environmental contamination has been assumed to disseminate spread within healthcare facilities. Also, the American Journal of Infection Control has recently published a study that highlights medical equipment as a potential environmental route for transmission. So this study actually looked at 3 different long-term care facilities undergoing COVID-19 outbreaks, and it was meant to assess environmental contamination by environmental sampling or swabbing of various areas within the facility. And what they found is they actually found this virus just kind of throughout, more specifically blood pressure cuffs, kind of the Velcro area, linen card handles, and then tablets that are used for accessing electronic medical records. So both, things that are frequently touched and shared by patients, and as well as healthcare workers. Next, please. It is also important to note that patient and patient bathrooms were excluded from sampling. And the reason for that is that the presence of the virus in these areas with positive residents is to be expected. So we know that we can't forget about cleaning of high-touch areas, which we will discuss in a minute. So standard cleaning practices, we know that may not suffice, especially if equipment is frequently used within a facility, as this allows for the virus to accumulate on surfaces. Frequently used items should be disinfected on a per-use basis, and then single-use disposable options for equipment such as those blood pressure cuffs and thermometers, things like that, should definitely be considered. Next, please. So we definitely want to establish a cleaning pathway to avoid cross-contamination within the facility. So we need to look at cleaning clockwise or counterclockwise, high to low, and then clean to dirty. What we see on the bottom right-hand side here is just an example of a cleaning strategy from cleaner to dirtier areas. So share equipment and common surfaces. We have items touched during patient care, and then kind of the most contaminated are patient indirect contact items. Next, please. When we're looking at semi-private rooms, it is important to ensure that the cleaning cloths that we're using are changed for each side of the room. And this is to avoid cross-contamination with the resident restroom always being cleaned last. This is also important in facilities that have a Jack and Jill type setup or layout. The rooms on both sides of that shared restroom should definitely be cleaned first, and then that restroom should be cleaned last. Next, please. And this is just a reminder of the resident high-touch area. This is a CDC Environmental Checklist that can be used for monitoring not only terminal cleaning, but also your daily cleaning, as we see some of the high-touch room surfaces that need to be addressed during that daily clean. Next, please. So when we're looking at staff areas, we want to dedicate resources to each cohorted area as much as possible. So this includes both staff and equipment. So we want to ensure the frequent cleaning and disinfection of countertops at nurses' stations, like we discussed based on the study that found, any kind of tablets, any kind of keyboards, phones, etc. Also, those frequently touched items such as linen cards, dietary cards, med cards, and then those areas that are shared by the staff as well, including break rooms and then restrooms as well. Next, please. So what we have here is the hierarchy of disinfectant skill. What we see on the pyramid is the organisms that are listed towards the top, are those that are harder to kill. So we're looking at prions, we're looking at bacterial spores, things such as C. diff, and then towards the bottom of the pyramid, we have organisms that are easier to kill. In this particular case, those envelope viruses, such as the SARS-CoV-2 virus. And one of the reasons that I wanted to share this is to emphasize that if you have an appropriate cleaning product and a process in place to ensure that cleaning and disinfection, you can significantly reduce the risk of transmission within your facility from surfaces. And this is especially true if you have ongoing COVID-19 outbreak. Next, please. So this brings us to the properties of an ideal disinfectant. This is we want to have a product that has wide antimicrobial spectrum, or that is broad spectrum. We want to ensure that products are EPA registered healthcare disinfectants. We've discussed in the past that EPA lists N. We want to have a product that is fast acting, or that it has a short contact or kill time. And a product that has cleaning and disinfecting properties, or ideally a 2-in-1 product or a one-step product. And then we always want to follow instructions for use. Next, please. So we want to look at a couple labels together. In this particular case, we see that we have a disinfectant only. It'll tell you that you have to pre-clean surfaces prior to use. In addition to that, if you want to disinfect, the contact time for this particular product is 3 minutes. So we know, we've seen it kind of time and time again, that once you have that two-step process, staff is less likely to be compliant with that. Next, please. What we have here is the label for a one-step cleaner disinfectant. It is broad spectrum, so far so good. It is approved for hard surfaces. As I mentioned, disinfectant cleaner. One of the barriers that we see with this product is that extended or prolonged contact time. Once again, that's another one of the things that we often see, that when you have that extended contact time, staff members may not be as compliant when it comes to cleaning and disinfecting. Next, please. The label that we see here is also for a cleaner disinfectant. This particular product has a contact time of 1 minute, which is great. However, it still does require you to remove gross soil if visible. So we see that, there are advantages and disadvantages to various products that are available. So I really want to challenge you to assess the products that you have in your facility. It is also, when we do site visits, not uncommon for us to see duplication of products. So, if you need any assistance with this, I encourage you to reach out to us, and we'll be happy to help you through that process. Next, please. So you want to implement standard operating procedures. So every facility should develop cleaning schedules. You want to identify the person that's going to be responsible. We know that cleaning, disinfecting is not the full responsibility of housekeeping, because we do have to take care of that medical equipment. We want to establish frequency, the product we're going to be using, and then that process for that as a method. And then detailed standard operating procedures for environmental cleaning of surfaces and non-critical equipment in every single area of the facility. Next, please. And then lastly, we want to observe compliance with dilution ratios. We know that we want to ensure the efficacy of the product that we're using, compliance with contact time. If we only have a disinfectant product, we want to ensure that cleaning has been done prior to that disinfection. We want to observe the high-touch areas for both residents and staff members, along with the common areas, such as break rooms and restrooms, things like that. Definitely cleaning of shared equipment, and observe the process for cleaning of those areas. Are we really following that established pathway? And then most of all, you really want to be meticulous. This is especially important if your facility is undergoing a COVID-19 outbreak. And that is all that I have today. At the end of the presentation, I have listed just a couple of resources that will assist you with this. But you're always, welcome to reach out to us to that email address listed. Thank you.
Thank you, Fabiola, and thank you, Vicki. Just a couple of things I wanted to emphasize from both of their presentations. So, I think something that may have fallen by the wayside that I want to continue to reemphasize is that if you have a resident, anytime that resident leaves his or her room, they really should be wearing a face covering of some kind, whether it's a cloth face mask or a surgical mask if you happen to have enough in your facility. I think, even, the goal of cloth face coverings is to protect others from the person wearing it. There may also be some degree of protection that's coming from that covering as well. And so I really strongly emphasize, just as we are trying to ask everybody to wear face masks when they are not able to adequately social distance, that also applies to the residents of your facilities. The same goes for your staff and your healthcare providers and healthcare facilities. They really should, if at all possible, be wearing surgical face masks when they are having encounters with residents. If you don't have enough surgical masks to do this, we recommend using a cloth face covering or some face covering, just because the risk of asymptomatic transmission is now recognized to be so high. In terms of eye protection, the guidance from CDC is that folks add eye protection to any patient encounter, whether or not you think they have COVID, in addition to that mask that you're wearing or face covering that you're wearing. just because in areas where there's substantial community transmission, which unfortunately Tennessee is in right now, you know, that your eyes and the mucous membranes of your eyes can be a portal of entry of those virus particles into your respiratory tract. And so that's just an added, I think, safeguard to hopefully prevent you from getting exposed to any of those droplets. Another practice that I would just encourage folks to do if you are not familiar with environmental cleaning, and I fall into that bucket, is just look at the cleaners around your house. So I have an empty jar of Clorox wipes. I've not actually seen Clorox wipes for sale for months, but I have an empty canister and was actually reading that the other day just to make sure I was doing it correctly. And, you know, those themselves say that the surface needs to be wet for up to 4 minutes, or excuse me, for at least 4 minutes for them to function in the way that you want them to. And that's something that I really did not pay attention to, I think, until this pandemic, where it became so clear that we need to be careful to disinfect and clean our surfaces. So, you know, there's a lot of different products out there. They all have different instructions for use. And we just ask that folks get familiar with those and get as familiar with those as possible. I know there's been a lot of questions coming. One that we've received several questions about is reopening of common areas and communal spaces in facilities. And so our Commissioner of Health, Dr. Lisa Piercy, asked that we put releasing this guidance on hold just in light of the increased case counts that are happening across Tennessee. We really want to try to pause transmission in facilities, particularly since we're seeing such an increase in outbreaks in long-term care facilities. So it doesn't look like that's going to be released this week, but I will keep everybody posted as we hear more about the status of that document. We've also gotten a few questions regarding the FAQs document from our Health Licensure and Regulations Division. I think that document is ready. And I think they actually were planning to email it out to folks today. Let me see if
Dr. Keating, this is Vincent Davis.
Oh, hi, Vincent. Thank you.
Hi, sure. Yes, that document has been mailed out to all of the long-term care facility administrators, nursing homes, ACLs, ACLFs, and RHAs. So you should have that document in your inbox.
Okay. We have received some questions about stopping admissions. So I can say that there's no specific guidance from the State Department of Health regarding stopping admissions in facilities. I do know that, you know, in metro areas such as Shelby County, Nashville, Sullivan County, Hamilton County, Jackson-Madison, and Knoxville, that those health departments have a different governing structure, and that in some cases those structures have recommended stopping admissions in some facilities just based on ongoing outbreaks. My group does not have control over that, and I know that there are some instances where regulatory authorities may recommend stopping admissions, but those are decisions that happen outside of my team's purview. And I will say that the recommendation at this time remains to not have group activities, including communal dining in long-term care facilities. We have not relaxed those restrictions, you know, in light of the increasing cases across the state. I think we're hoping to see, hopefully, we'll eventually see a decrease in that community transmission. But at this point, I don't think that it would be prudent to have group activities like that. I've seen a few questions roll in from the chat box about locating that threshold and what it means. So I can try to share my screen and show folks the best way to access that. 1 second. All right, so I will be the first to admit that I have not memorized the Tennessee Department of Health website. So I usually go to Google and type in Tennessee COVID and go to the top link, which is the novel coronavirus website for the Center for Environmental, or excuse me, for where we're housing all of our data. If you look at this landing page here and scroll down a little bit, you'll see the map of Tennessee, and it says click here for complete data reports. So you click on that. And it must know it's being watched because it's taking a little bit of time to load. All right. So looking at this web page, you want to go to this EpiCurves link here and click on that. We've also gotten some questions regarding delays in receiving lab results. I do know that that has been a problem in several labs, just as the number of cases have increased and the testing has increased. Some of our commercial labs especially have had backups in their reporting. I don't have a whole lot of information on when that will improve, unfortunately, but I will say that we are aware that it's a problem, and we are trying to keep a very close eye on those turnaround times. And I will keep you posted if we have any updates or additional updates on that. So again, on this EpiCurves page, scroll down to the one that says Tennessee COVID-19 recent case rates by county. So you have the ability to select the county that you're in here. So we'll just pick Cannon County at random. And you can see up here in the upper right corner, it says Cannon County is below the threshold. And it's a little bit confusing when you look here and you see, this red line, and there are some days where the case counts are over that 10 per 100,000 residents. But what we're looking at is this average rate of new COVID-19 cases per 100,000 county residents over the last 14 days. And if you look at that average, it's actually 7.64, which is below the threshold. Which is why this, facilities that are located in this county are allowed to have visitors. And some of the counties where there have been higher case counts, so the one that Vicki showed was Davidson County, which obviously is where Nashville is. It is above the threshold, and that's because it's had an average case rate of 40.34 cases per 100,000 county residents. So hopefully that makes it a little bit easier. I know it's not necessarily the most intuitive thing, but the goal of our unified command is to try to make sure that in areas where there's a lot of community transmission, that we protect those who are most vulnerable. And I think we've unfortunately seen instances that, where there is a large amount of community transmission of COVID-19 that impacts the nursing homes in those counties because of the employees and the exposures that they could have there. One question that might be a good one for either Vicki or Fabiola is what would be considered a short contact or kill time? Just relative, I guess, on the spectrum of different times.
This is Fabiola. So depending on the product, obviously, and the list is pretty extensive. So some of the shortest times that I've seen as far as contact time, about a minute, when you have a one-step cleaner disinfectant. Obviously, that will be affected, several factors that will affect, the contact time and whether you have a 2-in-1 product, things such as cost and dilution ratios. So you really kind of want to look at that as a whole. One of the links that I've included in the slides is a CDC, it's a more comprehensive list from the CDC of things that you should look at when you're trying to pick kind of that ideal disinfectant. The other thing to kind of keep in mind is some products, even though they may have a short contact time, they may not be approved for soft surfaces. So you may have to have, more than one product to be able to clean the surfaces that you have in your facility.
We received a few questions about beauty shops, and I will just kind of reemphasize we are not recommending reopening those at this time, although that guidance will likely come from our unified command when disease transmission in Tennessee decreases. But at this point, they've paused review and annotation of that document. And so my understanding, and Vincent and folks with health licensure and regulation, correct me if I'm wrong, is that the guidance still stands to not allow those facilities to be open.
That is correct. That is my understanding as well.
I will also say that if you are having concerns about identifying laboratory vendors or have questions in general about turnaround times, probably the best advice I would say is to email that covid19.testing@tn.gov. Those folks keep a really close eye on those laboratory turnaround times and other logistical questions, and probably have a better sense of how to handle that than I personally do, unfortunately. I will say that in terms of the eye protection recommendation that was made, that's guidance from CDC just as a safeguard for employees. It's not a mandate or a requirement by any means, but it's really just meant to provide an added layer of protection for your healthcare providers who may be coming in contact with others in your facility, whether it be staff members or patients who are asymptomatically infected with COVID-19. So that is a recommendation, and I think that it's really a good one just based on the fact that we want to protect our healthcare workers as much as possible, but it's not something obviously that my team can require or mandate. Another question we've had is regarding double masking. So I don't know if there's been any kind of systematic studies of that. I can say that I imagine it would make it more difficult to breathe and might have a comfort factor there. I don't know if any of the infection preventionists have any more information there, but I can say that, I think if you're wearing a surgical mask, one surgical mask would be sufficient. If you're wearing a cloth face covering, I think the current guidance is to wear one that, is made of a good, sturdy, high thread count cotton, or, multiple layers of that, and potentially with a layer, an outer layer that is fluid resistant. But I am not aware of any other kind of evidence out there regarding double masking. We also received a question regarding the appropriate storage of surgical masks. Vicki or Fabiola, do you have any guidance you could share on that?
This is Vicki. We just need to make sure that they're not plastic. It needs to be able to breathe and be able to dry out. So you wouldn't want to put them in any plastic type containers. We see a lot of them stored in like brown paper bags and stuff. So main thing.
Yeah.
Don't
and I actually saw
the paper bag. So the paper bag.
I'll also say. Oh, sorry. Go ahead.
The paper bag, it's a one-time use.
And I'll also just add, there was, I think, something on CNN maybe that showed somebody in the public storing the surgical masks in a plastic bag. And I don't think that's something we would recommend, just because, as you can imagine, if there's any moisture on that mask, it's not going to be able to dry. And it just really, because it will sit in that bag and not dry, it increases the likelihood that when you reach in to get the mask again, you touch it, and it's just not ideal. So the goal of the paper bag, I guess, is it's a breathable material, and it's something you can easily throw away afterwards.
Yes.
We also received a question about residents leaving the facility into the community. So I don't think there are specifically any mandates or requirements that say that this can't happen. I will just say that every time a resident leaves your facility, they are, at increased risk for being exposed to somebody with COVID-19, especially if it's somewhere like a hairdresser or somewhere else where, the people may not be able to follow the infection prevention and control precautions that you would see in a medical appointment or in a medical office. So if you're going to allow residents to do that, I would strongly advise making sure that they wear a mask and that they understand the risk of going out into the community. All right, we are actually over time, but I will send out these materials. I'll also send out the FAQ document that was referenced earlier with the call materials. But also I would check with your facility administrator who's on documentation that would be held by the health licensure and regulation folks, because they should have received that as well.
Dr. Keating, this is Vincent.
Yes.
Just in that regard, those will also be posted to the website that you showed on your initial slide.
Perfect. All right. Thanks, everyone. I hope you have a great rest of the week. And as always, reach out to us with any questions or concerns.